On the topic of prostate cancer, I realize that we're at a focal meeting talking about prostate cancer, and we're talking about BPH. I think it's important. I just wanted to mention this because I think that where that interface between BPH and prostate cancer occurs is important and very useful as a tool. So, if you have a 77-year-old man that comes into your office on Eliquis with 120-gram prostate, severe trilobar hypertrophy, and they have severe LUTS and a PSA of 12, the question is not, does this man have prostate cancer? The question is, if they had prostate cancer, would you do a robotic prostatectomy? Because if the answer is no, the next step is enucleation, or some removal of the transition zone with pathologic analysis with subsequent PSA assessment 3 months later. Because if the path comes back negative and at 3 months their PSA is 0.5, you're done. You fixed the problem and you diagnosed it as well. If it comes back as cancer, now you've set them up for focal therapy or radiotherapy. Now you fixed their lower urinary tract and appropriately presented them with the next step. So I just think it's really important to think about the transition zone and the peripheral zone and the patient in that setting, because the shortest way between 2 points is a line. So, all right. So I'm going to talk about optimizing BPH clinical pathway. I was supposed to talk about reimbursement, and I kept crying about it because I didn't understand anything about it. So I changed the talk. Consultants are the same. So somebody has talked about this in the past. The problem, we talked about the tsunami that's coming of patients, as well as the fact that the number of urologists in the market is going to continue to decline. I analyzed our catchment area. We're at 1.7 urologists per 100,000 patients. So we are struggling. We're drinking from the water hose to try to treat patients, accordingly. So what do you do in the long term? Well, we need more residency programs. We need more trainees. We need to have some value for durable treatments that have, like anatomic endoscopic enucleation, 1% retreatment for BPH at 20 years. But what about right now? And so I just wanted to talk about kind of how I run the clinic in terms of utilizing APPs and maximizing my efficiency. So kind of going through a journey of a patient, presents to the emergency room with a Foley catheter. Their first visit's going to be with a physician assistant. The job is make sure you're on the meds, rule out cancer, get rid of the catheter, start CIC if indicated, right? So just kind of get them through that hump, and they're not waiting 3 months for an appointment with the doctor. The next visit is going to be with me. Obviously, they were severe enough where they need to be evaluated. And so when they're seeing me, I have a cystoscope in my hand and a transrectal ultrasound. So I'm going to diagnose the problem, confirm that they don't have prostate, bladder cancer, or something else, stricture, stones, confirm the stability of the temporizing measure. How's the cathing? You're not cathing. You went back into retention 3 more times since I saw you. I think that's a really nice next step to figure out what's happened. And if indicated, go ahead and schedule the outlet procedure. Or, if there's a one-time event after they had surgery or something like for a gallbladder, and it turns out they have a fairly small gland and they're doing well on Flomax, you can continue the therapy with some of those findings there that you may see on cysto, which is quite diagnostic. Here's my plug for reimbursement. So if you're doing a visit and then you do the cysto and then you sit down with the patient and you have an entire consultation for surgery, and then you schedule a surgery, you make sure you use a modifier at 25, because you need to make sure you're getting reimbursed for this procedure as well as your level 4 visit that you've essentially gone through all this time and effort to go through it. You made it convenient for the patient, but you have to capture with the work that you've done. So the second visit, this is just what I do. So the patient watches a video. So I've made a video and I put it on YouTube, and it's my video that me on a whiteboard talking about HOLEP and other procedures, et cetera, and what the difference is. And it's really useful, I found, to record your own video, because the sort of psychological effect of the patient is, I walk in, I do a quick cystotrust, I make an evaluation, it's a clear-cut case, 150-gram prostate, urinary retention 3 times, bladder stones, like he needs a HOLEP and a cystolithopaxy, at least in my hands. And so they just need to understand all this information. I walk out of the room, they watch the video, I go see some more patients, I come back in the room and I say, okay, we answer some questions that are specific to their case, take another 5 minutes. I've probably spent 9 minutes total. The patient says, thank you so much for all the time that you took to explain things so thoroughly. So I think it's really important you're not using a stock video. Record your own video and then see how you can integrate that into your practice to improve efficiency. I have a QR code on a pamphlet that they can watch the video with their wife at home. So got to keep re-emphasizing all of the education because there's too many patients and there's not enough doctors. So we have to educate the patient, not sacrifice the education and the care, but we have to keep moving forward. Otherwise, we're not going to be able to handle the next 20 years. The third visit is going to be with an APP again, the same one that they saw the first time. So there's some continuity there. It's really just dot the I's, cross the T's, set up the expectations, stop your Eliquis, get a urine culture, are the clearances done, et cetera. Fourth visit, so that's the second time they're seeing me. Now they're seeing me for surgery, right? So first time they saw me for a cystotrust procedure consult, now they're seeing me for surgery. So both times I'm doing a procedure and making the patient move forward in the pathway. 3-month post-op visit with an APP, they're doing great, stay with the APP. If there's a little bit of an issue there, maybe a little bit of physical therapy, maybe they have severe OAB, they needed to start some OAB med, and then they continue with the APP for about a year, and then eventually if they're cured at a year out, their PSA is 0.5, their urinalysis is clear, their PVR is 0, they're happy with their outcome, their path on their holdup was negative, you don't need a urologist anymore, man. Come back and see us when you need us. But if there is a non-surgical issue, they'll typically kind of work it through with the APP, and if it all gets resolved, they kind of go back into the same pathway. And it requires a lot of sort of training. You have to get somebody that you really invest and train the APP that you work with and take the time and answer the questions because it's not an autopilot. You have to put in the work to make this work. But let's say none of those things are working, right? They're having problems, they're still having hematuria 3.5 months later, they're having incontinence that just doesn't seem to make sense, or there's some other issue, another stream is slowed down. Well, they're gonna see me again, and I'm gonna have a scope in my hand again, because I'm trying to rule out urethral stricture, rule out bladder neck contracture, rule out dystrophic calcifications, rule out some kind of problem that's occurred as a result of the procedure. And maybe, if everything looks great, and it still doesn't make sense, I might get a urodynamics after the fact. And again, if there's something to correct, the 7th visit, right? But again, the 4th visit with me is some sort of intervention, whether it's going to be Botox or maybe one of my partners might put an InterStim in or something like that. So, the idea is that as we move forward in the future, we just really have to think about that patient that's in our office that you're refilling Flomax for. And whether that makes sense for the community and for our field in general, because we're not going to be able to generate all of a sudden out of thin air all of the urologists that we need, but we can figure out a way to work well with the people around us, and you build a good team around you, you can hopefully take care of the people that need it. So any questions on that?